Great, thank you very much. Right, we're going to move straight on to our next plenary speaker, who is well known to many of you, I know. So Professor Olle Cate is going to present Rethinking the Nature of Veterinary Competence to Serve the Education Practice Continuum. I'll give a short and spiel because you've done an awful lot, Olle. So Olle has a background in medicine and a PhD in social sciences, and has spent 4 decades advancing curriculum innovation, educational research and faculty development at the universities of Amsterdam and Utrecht. He founded and led the Centre of Research and Development of Education at UMC Utrecht, and served as president of the Netherlands Association for Medical Education. He's authored over 500 publications, 600 presentations, and has many, many awards. And it's my great pleasure to welcome him here today. Olle, do you want to take the stand?
Good morning, everyone. Thank you very much for the introduction and for the invitation to speak today. I will speak with you about rethinking the nature of veterinary competence to serve the education practice continuum. And of course, I'm not a veterinarian, and my knowledge is more about medicine, but I think there's so much overlap that we can easily make that translation. I have no conflicts of interest to disclose, and I wanted to start with a question for you if you are veterinary educators. Can you remember if you've ever personally signed off for the completion of a program or a rotation while you were not fully confident that the learner had met critical objectives? And if you have a smartphone and you have that experience, why don't you see if you can give an answer to that? So can I ask in the back of the thing, back of the hall? Yes. We have no answers yet. No? Can we go back? We can, because yes, here we do have answers. So, and I think it's we have 23 people who answered this, and I can tell you that this is not unusual reaction from audiences. This is what I have collected over a couple of years, the past some years, that I asked the same question to audiences. And you can see that 60 or more percent have that experience, that they signed off for completion of training while they were not fully confident that a person had met critical objectives, or they were not, say, I will have my own family members treated by this person, or I would hire them in my own department when they apply for it. So this is an example, and just remember it a few times if you, during this talk, about what is actually competency-based education. Competency-based, if you define it, it's education aimed at a standard level of proficiency for all graduates, and having fixed, and actually moving from a situation of a fixed time of training with a variable outcome among trainees to a situation of fixed outcomes and, if needed, variable time in training. So critical features of competency-based education are that you need a clear description of standards of a good health professional. You need assessment of all trainees using these standards and having competence and not so much time in training be the critical reason to finalize training. The whole idea of competency-based education is widely accepted to prevent graduating unprepared trainees, which we just saw that happens every once in a while. It may not be frequently, but many people have that experience that it happens. And those competency frameworks have been, as I said, widely accepted, but also have been criticized as being too detailed, too vague, too remote from clinical practice. And so maybe we should start thinking of how to define what is competent and what is competence, And I'll come to a solution of the idea of those frameworks that are not always as useful as we hoped they would be. Let me start by just depicting a traditional but dysfunctional view on competence acquisition that's probably held by many people in the world, also outside academia, outside medicine. And there is education, there's a phase of education, and during that education there's no permission to practice, and after the education there's full permission to practice. And during that education, learners move from being a novice to being an expert. And then there might be a licensing exam if there's education with a licensing exam. And lo and behold, for the rest of their professional lives, they are experts and they can actually practice. That's what we hope, that's what governments think, and that what many people in society actually think. What is really true is that development looks like this. It is actually like shaped in a curve like this. This is a much more functional view of competence acquisition. There's a training period, and even before that training period, there might be some development. Definitely after that training period, there's further development. And there is that one moment, that threshold moment, you could say, this person is now ready to start practicing. And if they start practicing, of course, they will increase in their knowledge and skills. That moment might be, for some people, might be even earlier than the standard duration of the training, might also be later than that standard duration of training. And that's for the whole domain of what's needed, but you could also break that down into specific activities. So one trainee's readiness for a veterinarian activity may be different than for a different activity that they have not experienced so much. So there's variability in different ways. So that's one thing to remember. I'll come back to the curve too. Now think about what is competent. And there's basically two ways to look at that, from a retrospective perspective and in a prospective way. The retrospective way is actually answering the question, has the trainee or does the trainee show the mastery of the content taught in courses and rotations? Did they pass their exams? Were they observed and were signed off? That's basically, if you look at that, the picture down, it's a university question. It's an educational question. Can we sign them off? Did they do everything we asked them to do? Now, the prospective part of competence is actually a different question. The question is the trainee really ready to be allowed to assume their expected future responsibility? That's not so much an educational question, but actually a healthcare question. So that is actually what we're also training for. We're not just looking back and see, did they do all we wanted to do? We'll sign them off. There's no reason not to sign off. They're at the end of training. They passed everything. And still, for some trainees, you have that nagging feeling, are they really ready for practice? Maybe not. 60% of people would remember they signed off, not completely confident. And if you think of the word competent and you look at the dictionary, it actually has two meanings. One is ability because you've been trained to do things, and the other was an entitlement or permission or have the authority to do things. If you think of a competent body, they are entitled to judge or make decisions that otherwise other people may not. So that is actually the prospective side of it. And if you think of that, yesterday we climbed Miller's Pyramid. Let's do that again. So Miller's Pyramid, as you already know now, was actually created to give approaches to assessment of learners during their education, from knows how, applied knowledge, shows high is that integrated knowledge and skills, and then does would be the integrated knowledge, skills, and attitudes observed in a context. And that was, are they doing well? The does actually say, are they doing well? Can we see that they don't make mistakes? And so that's not exactly the same question, is are they ready to practice without any supervision? Can we really trust them? So you might think of the estimated readiness for future demands is being trusted to practice healthcare. So that could be seen as an even higher level than just observing if they do well in clerkships. So now if we think about trust and entrustment with tasks, the question is how in the development of competence, how in the conceptualization of competence does that fit? So how does entrustment fit in competence development? And I would like to take you on a little journey to reconceptualize what competence actually is. And competence may be seen as a hierarchical, multi-layered construct. And we describe that. If you want more details, this is a publication that you could look at. And what we actually suggest is that competence can be seen in 3 layers: a canonical layer, a contextual layer, and a personalized layer. Looks like this. Canonical competence would be the knowledge and skills that are context independent. So they would apply anywhere. Anatomy of the body, basic physiology would apply to maybe even different species. I'm always very, very impressed about the veterinarians who actually attend to so many species, and the human medicine people only to one. But that is also part of the context, probably. So that is knowledge and skills that are context independent. You may expect that people, any physician or any veterinarian has that competence. Then there is contextual competence. That is the ability to apply things in a context and to adapt to contextual diversity, to be able to work in different contexts. And then there's personalized competence. So if you're meeting that, in that hierarchy, actually, you're meeting those standards for canonical competence and standards for contextual competence. Here's where personalized competence could lead to individuality and something that you would call the art of patient care. So this is standards. I think it shows some of your standard work that people would recognize. And then there's contextual competence. That is, do you understand local habits, local protocols? Can you work with a team that works in that context? And personalized is realizing that all individuals are different. If you're a specialist, you may have your own style of working, and so that could be called the art of patient care. Let's go a little bit deeper. So the word canon comes from Greek. It's the general Catholic law, rule, principle, Bible books, all called canon. It's basically what it says is that what everybody should know. And canonical competence in medicine should be undisputed. Standards should be general across context and schools. And the mechanism, of course, should be in place to update the canon. What we have as a canon now may be different than 20 years from now. It may also be different from 20 years ago. So there should be a canon that is expected that everybody should know, that holds for the general competence, also maybe in a specialty, and that should move along. But that should be what you can expect everybody should know. And then assessment of learners should and can be psychometrically reliable. Now, contextual competence is competence to work in a context. And this is one of the studies that actually show that learners, even if they have canonical competence, work in a context and need to observe how clinicians actually work and to adapt. And this is a quote from it: continuously moving between knowledge and skill foundation, recognizing where and when contextual differences require new learning and adaptation. Is that a quote from a study that they did? So that layer 2, contextual context, is the ability to apply canonical competence and skills in a clinical context. In fact, in different and varying contexts with rules, habits, procedures, team members, local protocols. And the standards of competence cannot be absolute. They must be locally interpreted and complying with local conditions. And the focus of assessment is then actually readiness for entrustment with healthcare tasks. Teaching should foster progressive autonomy with healthcare practice. And here we come on the word entrustment, according to the Oxford English Dictionary, is entrust to assign the responsibility for something valued, for instance, to a person, to an organization, etc., or to put one's trust in a person, organization, with regard to a particular task or responsibility. That is actually the little definition of entrust from the dictionary. So we use that to create something that is called entrustable professional activities. And it's defined as a unit of professional practice, a task or responsibility that can be fully entrusted to a trainee once he or she has demonstrated to have the necessary competence to execute that activity unsupervised. And it's actually created to help operationalize competency-based medical education, or in your case, veterinary education, through a stepwise and safe engagement of trainees in clinical practice with progressive autonomy. Now, let's define competent then. An operational definition of competence is when a professional activity is mastered at a threshold level that permits trust in a learner to act unsupervised. So if you think of it, there is a whole curve. It's a stage in a developmental continuum. And here I have that same framework that was used yesterday also, from novice, advanced, competent, proficient, expert. It's a framework of steps in development by Dreyfus that has been used in medical education a lot. So if you think of training and you think of that word competent that they placed right in the middle, it's not on the top. It's in the middle of that framework. And there is a threshold level that a person is ready for unsupervised practice. Now you can apply that to a whole domain. You could apply that to individual EPAs. So an entrustable professional activity for one trainee could look like this, but a different EPA might be easier. Another EPA, you don't even start training that person until the second or third year. And there's another one, it's easy. If you draw that same threshold of competence, evidently you could see there's more different moments in training that a person is ready for unsupervised practice. And if you don't practice after you've been qualified to do that, you never practice anymore. You might even drop in your skills and knowledge and may not be trusted anymore after a while. So that's working with EPAs. And if you would look at workplace-based assessment, this could be, you can envision this as a way actually to know that person are ready for that EPA. So there's multiple, we call that ad hoc entrustment, that you would say, no, just go ahead and try, and we'll watch you and we'll observe you, and then we'll give you, we'll evaluate you, give you feedback, and then do it multiple times until you get better and better and better. And meanwhile, you have your portfolio, and every time we observed, we can put some information in your portfolio that actually documents that progression. And then if you have progressed enough, you might be ready for a summative entrustment decision. And that's actually that threshold moment that actually you, as an organization, educational program, should be allowed to, or be able to say, this person is now ready to do this work with limited supervision. And there could be different moments, as we've seen in different moments for different EPAs in their training, also different for different individuals, because they're not all the same. But at the end of the day, you would like to see that everybody really is ready to practice all the important and trustable professional activities. So here is the suggestion that you use a committee, a team of educators that actually looks at that information and in a way that the most valid way, and makes that decision that it could be a clinical competency committee. Sometimes people call that an entrustment committee, to give a person a STAR for that EPA. And a STAR is an acronym for a Statement of Awarded Responsibility. So now we say you can have that responsibility to start doing this with little supervision. And that's entrusted with increased autonomy. So that was all layer 2. Remember, so we're still talking about contextual competence. The layer 3 is the personalized competence. Let me go a little bit deep on that too. So personalized competence reflects the legitimate differences in style of patient care. It makes veterinarians unique in their excellence, and it turns science of healthcare into an art of care. And if you think of other domains like artists, actors, architects, restaurant chefs, industrial designers, and other professionals, they all meet important canonical knowledge and standards of knowledge and skills, but they're often mostly valued for their unique style. So a key concept in personalized competence is the word PGVE. So let me make a small detour to explain what PGVE actually is. You may never have heard of the word. So personalized competence stemming from PGVE. Here's a person, may not be able to recognize this person, but he's called Lev Vygotsky, was a developmental psychologist, and he's famous for things that we've used in our education, like the zone of proximal development and cultural historical activity theory. But he studied, and not many people know that, but he studied the emergence of artistic excellence. And there he used that concept of PGVE very often. Now, it's not so easy to define what PGVE is, but it combines experiences with emotions and subjectivity. So if you would combine that into a definition, Vygotsky's interpretation of that is the subjectivity which makes individuals unique in their creative performance, being the resultant of combined cognitive and emotional experiences built across one's lifetime, integrated in their long-term memory, and informing one's frame of reference in viewing the world. So it's a long definition, but it gives you, so every individual is unique. We have to recognize that. And they all come with a lot of experiences that are different from other people. So as long as you have the canonical and contextual standard, you meet that standards, you'll develop in a unique way. So you can just ask yourself, when does a vocation become an art? Here is a vocation also actually becoming an art. And if I looked around in this building, actually, it's a functional building, but it's also a building of art. Actually, the whole building is an art. Or a musical instrument, of course, is a functional instrument, but some people actually make those musical instruments in a way that are unique. Or you could say before photography, we needed painters. Now we call those paintings art. We don't call them a photograph. Or if you think of art, just think of Picasso. Picasso once started to be trained in his canonical, foundational canonical skills. And if you look back in how he started, a very naturalistic painter, and how he ended actually at the end of his life, there's a huge difference. And if you look at stages in his development over time, just decades apart, you could gradually see how he actually developed his personal style of working things. So that's an example. Here, I would also like to allude to something that was yesterday. Martin also alluded to Maslow's pyramid, and it's interesting to think of that same way. So Maslow also created that pyramid with how are people actually developing their unique motivation to do things. And on the top of that pyramid, after meeting the standards for physiological conditions, safety, belonging, esteem, cognitive, and aesthetic, there's self-actualization, or sometimes also combined with transcendence. So the self-actualization is the desire for self-fulfillment, to become actualized in what one is potentially, varying greatly from person to person, and being creative, relatively unfrightened by the unknown. I really love that quote, relatively unfrightened by the unknown. When you are an experienced professional, at some point you would say, I don't mind to see all sorts of new things that I've never seen before, because I think I have enough experiences that I'm not frightened by new things, that we'll just see what's happening, what's going to happen here. So if we think of those three layers, we think of preclinical, clinical, postgraduate, and post-certification. There's a different way. I would call this hierarchical, but not fully sequential. That means that those three elements come back at any time, but not in the same ratio. I would say there is an emphasis on canonical competence development in early stages, and at the end there is much more emphasis on personalized competence. And if you would summarize that as, again, canonical competence is what everybody should know. It's context independent. Core knowledge and skills are important there. Standards are generalized across even a country, could be even internationally good. And there's determined by an external body. Learners' progress decisions are most important for the assessment. You want to assess that learner can progress further. And quality is measured by psychometric standards, and identity formation is a professional foundation, I would call that. And diversity is actually disregarded. We don't look at diversity of individuals. We use the same standards for everyone. Now, if we go to contextual competence, that is being trusted to practice, is actually, that's the purpose of that contextual competence. And it's context dependent, not independent. It's contextualized knowledge, skills, attitudes. The standards are localized. They have to meet the standards that are useful in that context. And local expert teams determine those. And entrustment with care is the reason for assessment, not so much learner progression. And then the quality guarantor is intersubjective expert judgment. So you have experts who have seen that person as much information as you can get, and then make a decision. And identity formation, here is where professional identity is really formed. And then diversity is not disregarded, it's acknowledged, but still you want to make sure that this person can work in this context. Now, personalized competence is the art of patient care. It's individualized. Content is personal healthcare style. Standards are personalized, so you make your own standards. They are self-determined, and the idea of the assessment is actually for continuous quality improvement. So your standards are, if you've done something, you think, well, maybe this was not the best way, next time I will do it different. So it is still towards continuing quality improvement. And quality guarantors are patients and peers, and the identity formation is actually the merge of personal and professional identity. And diversity is actually valued. We like to have a diverse healthcare workforce. Then if we go to contextual competence, I would like to, one of the last slides would be to go back to competence acquisition, this slide, and we have to realize that this is a critical phase in the development of competence. It is that transition that requires attention. So as transitions to practice, features to keep in mind are that from undergraduate to practice or for postgraduate to practice are significant transitions, and passing that threshold of competence means that a person can safely do that. But initially, maybe with adapted caseload to manage cognitive load, they can do it, but don't ask them to be an experienced veterinarian like 20 years in practice. They need to be treated somewhat differently than an experienced person. Entrustment with an EPA, like qualification at an entrustment level 4, includes situations not yet experienced. And readiness for full practice may include some EPAs at an entrustment supervision level number 3 that we call indirect supervision, ready for indirect supervision or even lower. And all in all, support and trend around that transition period is needed. And here I have a new version of this, my slide set that I gave yesterday but they put the old version here. So let me, instead of showing those slides, I would like to explain that example. One example of an entrustment decision is the driver's license. So if you think of a driver looking at, I would say, a young trainee and say, well, this person is ready for the driver's license. The picture I had there, you could see that they were sitting next to each other in a car, and this instructor thinks she's ready. I think I can sign her off for the license. Of course, there's information needed. There is a written examination, and there is there's also, we have to have an examiner who also looks at that, but that person is ready. And now, if you give that license and you think of the word trust, we have to realize that you're trusting persons with, when you qualify them to do things that you have not observed. So the instructor has not observed everything that the license includes. Now, if you think of a driver's license, just think of driving in a storm, or driving, if you cross the channel, driving at the left side of the road. So if the Dutch license will allow you to do that, you've never seen that, and the instructor has not observed that, they're signing off. They're signing off their things that they have not been able to observe, or to drive in the Alps on a small road that you cannot even pass each other. So then the question of the instructor, when they think, am I signing this person off, should actually be, what if this girl would be my daughter's friend? Would I trust them to go on a driving vacation after this license, maybe in a few months from now? That's a good question to keep in mind. So we don't have those slides anymore, but I explained that to you. So here's one of the ways that you can think of. If you have that transition, you come to a next phase. For instance, you're qualified as a veterinarian and you start working in a context of critical emergency veterinary care. You could actually define the EPAs that are critical for that practice, and together with Robert Favier, who was sitting here in the audience, we actually created a suggestion, a list with the suggestion that on day one, when you're employed, the employee may think about these EPAs just by themselves. Am I ready to do this, and how much supervision would I require? You can actually do that. You could actually have them sign that, look at that, and in 5 stages. I have not gone in deeply into what those levels are, but basically they are, you could do that together with somebody else, you could do that with direct supervision, you could do that indirect supervision, unsupervised, on day one. To discuss that, and if you want to see more of that, this afternoon, Robert will have a presentation about this too. To wrap up and to take home, most of healthcare profession is of good quality, but there is too little attention to individual training pathways. It is helpful to think of veterinary competence in 3 layers: canonical, contextual, and personalized. Canonical is what everyone should know, easy to test, but not enough for practice. Contextual is readiness to be entrusted with professional activities in varying contexts. And then transitional phases require support, and that's still in that same phase of contextual competence. And personalized competence then is the freedom to develop further on a foundational knowledge and skills, relatively unfrightened by the unknown. So thank you for your attention. This last slide is just, if you would like to know more about EPAs, more about entrustment decision making, there's 2 sources. One is a book that you can actually download. Don't buy it because it's open access and you can download all the chapters. Or the other is to attend a course if you want. We do give regular courses, international courses about these. That's it. Thank you.
Hello. Thank you very much, Olle. That was fascinating, and it's such a well-used model, and so nice to hear about the wider context around the framework of EBAs, because I think a lot of the narrative is understandably around the assessment of them, but to look at the different layers of competence, it's wonderful. For any questions, I'm sure we do already. Yes, please go ahead.
Thank you for that. That was just absolutely fascinating. It was really interesting. I have a question which might have a supplementary question at the end of it. And I was just interested when you talked about diversity in the third personalised competence. Could you define what you meant by diversity in there? And then maybe there's a second question once I've understood the definition of it in that context.
Yeah, diversity. So I'm happy I'm not in the United States, because there's where diversity is something that you don't want to talk about anymore. So diversity is basically the idea is that it's maybe more in a very general sense. It is that we acknowledge that everybody is different. So the fact that you have a diverse population. So usually in human healthcare, we like to acknowledge that it's important to have a diverse population, because patients are diverse, and you don't want a healthcare that's only like senior white males who provide healthcare. But there's males and females, but there's also people from different origin, and maybe so that diversity is not something that we would value if we look at canonical competence, but in personalized. It is also a way that people develop. So it's personalized in different ways, but that diversity is very good. And sometimes if you have people talk about their general practitioners or their family doctors, you sometimes feel that there is a click between the family doctor and the patient. So because they go along very well, they understand each other, and that might be different from different people. So you might even think that my general practitioner might be different than the one my wife would actually most appreciate. So some sort of diversity there is good too, and much of that you don't even see as a patient, the way people operate. I've been working with the surgeons in the United States for about EPAs in surgery, and here we acknowledge too that surgeons even do the same operation. They do it in a different way. They even have their own standards on top of what they are supposed to do. They have the different ways to do that. And that's one of the studies that I showed in a picture, is that the residents actually need to navigate, because at one day, their surgeon said, this is the way to do it. And the next day, they go to a different surgeon, and they say, no, this is the way to do it. So there is diversity also in their, I would say, the way they develop their own competence, because they have learned from their own experiences, this is the way that I would like to do it. And if you go deeply into that PGVE idea, you could say that even you have your own history also determines how you interact with other people, how you interact with your team, how you interact with your patients too.
My second question, and I really appreciate that, is why is it only recognised as an individualised, sort of personalised issue, and not earlier in the training and not earlier in the development of competence?
Yes, so it is, I would say it's not recognized, but the emphasis of education in an early phase should be on the things that everybody should know. And even in there, you could start seeing that individuals have their own interests, and they would be already, the seeds are there for their personal development. But the emphasis of education should not be on all the whole personalized idea. So the personalized competence, even though the development starts early, the real significance is when you actually have mastered the profession enough to be relatively unfrightened by the unknown, and then develop your own way to do things. And that's actually, I like to quote you for a different reason. So I know there is an issue with attrition in early practitioners in veterinary medicine. And that's for the one reason is that they don't feel that they don't feel that motivation and security that they would like to have to keep practicing. And if it's really true that the attrition is much more in the first 5 years than after that, that's a sign for me that there is that phase that they need that support to develop that stage of, I would say, self-actualization, as Maslow says, or that stage of being relatively unfrightened by the unknown.
Thank you. I think we have a question here at the front.
I don't think the microphone is on.
Is that right? Yeah. Whether you can advise me and perhaps the Royal College of Veterinary Surgeons of the end of the top of the pyramid and the end of the graph, when does that start to come down again? And can we trust the people who are experts but are now going downhill? How do we get rid of them politely?
Yeah. So it's a very good question, and frankly, what I hope and has not been realized yet is that if we think of entrustable professional activities, you would actually establish a portfolio of valid EPAs across a lifetime. But that portfolio is a dynamic portfolio. It really means that you have been trained to do things, and then after a while, even after you're qualified to practice, you maintain some of these EPAs because you keep doing that work. And if you don't keep doing that work, you should lose that EPA. Actually, it should lose the qualification to do that unsupervised. If you would pick that up, you would need supervision. At the same time, there's new things. So you should be able to add EPAs to that portfolio. And that portfolio of EPAs actually should be the best reflection of your competence to work unsupervised at any time in your lifetime. So, and it's interesting that there are some steps being done in that direction. In the Netherlands, postgraduate nursing training is all revamped to working with EPAs as building blocks. And other nurses are becoming much more diverse. Like nurse specialists are becoming much more diverse because they are interested, if they work on an ICU for a while, but they would like to work on an ambulance, part of their training is useful. They can use those building blocks, but they need to add new EPAs to their portfolio to be able to do that actually. And so they are developing that dynamic portfolio. Now, your question is probably also, how do we monitor that, and how is a governing institution or organization actually controlling that? That's not a very easy question, but it starts with a mindset of you want to be trusted to work with the things that you're actually doing. You don't have to be trusted for the things that you would never do anyway. So I know as anesthesiology program director who was a professor of anesthesiology, and you said, how do you know to do intubation? He said, well, I don't do intubations anymore. So the senior residents are excellent at doing those intubations. And I've never done that for 10 or 20 years. So I wouldn't trust myself to do that anymore. So you might even think of self-monitoring about EPAs. If you think of it, maybe I should not do that. And if I have to do it, I'd rather have somebody next to me to supervise me. Even a senior resident may supervise a senior clinician to do something if they're better at it.
That's great. Thank you very much. Thank you, Olle. Actually, that's really food for thought. So we use EPAs as a chapter in the portfolio for new grads, linking back to what we were talking about yesterday. So there's nothing to stop those using throughout their career, right through their career, I suppose, in terms of CPD. So thank you very much.